We are back with another series. Let's revise PYQs. This will benefit you in your upcoming exam. Let's look at the first question from this video. Question 1. An adult man in a restaurant suddenly begins choking on his food. He is conscious. The following procedure was performed. Identify the procedure. Your options are. And the correct answer is hind legs maneuver. Here's the explanation.
Now, if there is a foreign body, if there is a patient who's choking on a dinner table and was eating and suddenly started to cough, and you're thinking that now the patient is having a foreign body in the airway, he is not yet turned blue, there is no respiratory distress, and it is causing a partial obstruction. What will you do? You will do this maneuver, which is called as Heimlich's maneuver. So what is this maneuver called as? This is called as Heimlich's maneuver. Now, what is this Heimlich's maneuver? The patient is grabbed from behind and given compressions on the xiphisternum. And while you give compressions, you are going to give palpatory thuds, or you're going to give back slaps. So these together, so you'll compress on the sternum and you're going to give back slaps. That will help in pushing the foreign body out. This maneuver is called as Heimlich's maneuver. But in infants and children, you cannot do this. So in infant and children, you'll hold the child in your hand in the prone position going downwards, or on the thigh you will hold the child, and from behind you will give back slaps. So that is the maneuver that you do in infants and children. For adults, you will do Heimlich's maneuver. But if you think there is a complete obstruction of the airway, you won't do Heimlich's maneuver because it will only increase the obstruction. Only for partial obstruction, you will do Heimlich's maneuver. But for complete obstruction, you will not do because it will only increase the obstruction.
Question 2. In a 10-year-old child with symptoms of throat pain, fever, and ear pain, the diagnosis is recurrent tonsillitis. Which specific nerve is associated with the ear pain in this patient? Your options are. And the correct answer is tympanic branch of the glossopharyngeal nerve. Here's the explanation.
Referred otalgia is a condition where the cause does not lie in the ear, but the pain is referred to the ear via the nerves that supply the ear. So we've learned that the ear is supplied, the pinna is supplied by different nerves. We remember by the mnemonic LAG. L stands for lesser occipital, A stands for auriculotemporal, T stands for greater auricular. So lesser occipital, auriculotemporal and greater auricular. Along with that, we have the 7th nerve and 10th nerve supplying the pinna. Okay, so 7th nerve is basically a sensory nerve, and 10th nerve also supplies the region of concha and the retroauricular sulcus. So lesser occipital comes from C2, C3. Greater auricular also comes from C2 and C3. So lesser occipital C2, C3, greater auricular from C2, C3. Auriculotemporal nerve is a branch of the trigeminal nerve, and then the vagus nerve gives a branch called as the Arnold's nerve, which is nothing but the auricular branch of the vagus nerve. So all these nerves supply the pinna. We have the external auditory canal supplied by the auriculotemporal nerve, which is a branch of the trigeminal nerve, and we have the auricular branch of the vagus nerve called as the Arnold's nerve supplied by, which is a branch of the 10th nerve. We have the middle ear being supplied by the tympanic branch of glossopharyngeal nerve. So this tympanic branch of glossopharyngeal nerve, we call it as Jacobson's nerve. So we know all these nerves supply in our anatomy part itself. Now, can any of the nerves, the Jacobson's nerve, which is a branch of the 9th nerve, the trigeminal nerve, C2, C3 nerve, auricular branch of the vagus nerve and the trigeminal nerve, can they have supply to other parts of our body, and from those areas can we have referred pain to the ear? Yes, this can happen. How? Let us see. So if you have any lesion in the area of distribution of the trigeminal nerve, Say for example any dental pain or pain at the anterior part of the oral cavity, like say the anterior 2/3 of the tongue, the TM joint pain, all these areas are supplied by the trigeminal nerve. So in these area of distribution of trigeminal nerve, if you have a lesion, for example a patient comes to you with a lesion on the right lateral border of the tongue in the anterior 2/3, complaining to you with pain in the ear. This is referred via which nerve? We know anterior 2/3 of the tongue is supplied by the lingual nerve, which is a branch of trigeminal nerve. So from the tongue, the nerve that is responsible for picking up the sensation is the trigeminal nerve, and we know trigeminal nerve supplies the pinna and the external auditory canal via the auriculotemporal nerve, and this is how it causes referred otalgia. Similarly, temporomandibular joint, the parotid, the oral cavity, all of this will cause referred otalgia via the trigeminal nerve. So in the area of distribution of the trigeminal nerve, if you have a lesion, there can be referred otalgia via the auriculotemporal nerve. Now what about the oropharynx? The oropharynx is supplied by the glossopharyngeal nerve, the ninth nerve. So if there is a lesion on the posterior 1/3 of the tongue, or if there is a lesion of the tonsils, or if there is a lesion of the posterior pharyngeal wall at the level of oropharynx, all these pains are radiated via the glossopharyngeal nerve. And this glossopharyngeal nerve supplies the middle ear, the tympanic branch, and that can cause ear pain. So oropharyngeal lesions are via the glossopharyngeal nerve.
Question 3. A 20-year-old male patient presents with unilateral nasal obstruction and recurrent bleeding for the past 1 year. Transnasal endoscopic results are shown below. A contrast, enhanced CT revealed a mass extending from the posterior choana to the nasopharynx. What is the most likely diagnosis? Your options are, and the correct answer is nasopharyngeal angiofibroma. Here's the explanation.
So we can classify the symptoms as per the table that has been given here. We can classify it as bleeding symptom, obstructive symptom, and cranial nerve palsy. So in the bleeding, recurrent unprovoked profuse epistaxis, obstruction of the nose causing frog face deformity, hyponasal speech, difficulty in breathing, and eustachian tubal obstruction resulting in serous otitis media. Cranial nerve involvement is from 2nd, 3rd, 4th, 5th and the 6th cranial nerve. Now let us quickly see what is a frog face deformity. You can see there can be swelling of the cheek, widening of the nasal bridge, proptosis of the eye. This deformity is called as frog face deformity. On examination, now you know the symptomatology of a patient with angiofibroma. You know the age, you know the sex, how is it visible histopathologically. You note the symptoms depending upon the gross origin and further spread. You know all of that. Now, what will it appear to you on clinical examination? So, juvenile nasopharyngeal angiofibroma can be diagnosed by doing a simple anterior rhinoscopy. So, when you do a simple anterior rhinoscopy, you can see a globular red mass that is present in the posterior end of the nose and the nasopharynx. This is very vascular and you can see dilated blood vessels on the surface. You can do a posterior rhinoscopy by putting a mirror in the oropharynx behind the uvula and seeing the findings or the mass in the nasopharynx in the mirror as well. So you can do a posterior rhinoscopy to confirm the finding where you will see a pink to red globular mass occupying the nasopharynx. Do you want to do a probe test? Do you want to do a digital palpation? Never ever in a patient with juvenile nasopharyngeal angiofibroma, because if it starts to bleed, then it is going to be profuse torrential bleeding. So never ever do a probe test or digital palpation for a patient with angiofibroma, and they are contraindicated.
Question 4. A 5-year-old child presents with reduced hearing for the past 2 to 3 months. The otoscopy finding is given below. What is the most likely diagnosis? Your options are, and the correct answer is serous otitis media. Here's the explanation.
Why otological signs? So typically when there is allergy, there is nasal obstruction, and when there is nasal obstruction, the ventilation to eustachian tube gets affected. And once the ventilation to eustachian tube gets affected, it can result in middle ear disease. The most common middle ear disease that you will see will be serous otitis media. Serous otitis media, non-suppurative otitis media, secretory otitis media, or glue ear, all of them mean one and the same. So allergic rhinitis is a very important cause for serous otitis media. Now what image is shown to you and what are the findings you see? So typically the image that you've seen is the tympanic membrane, and you can see here typically the presence of air bubbles. So whenever you see the air bubbles and whenever you see the air fluid level, these are very characteristic features of serous otitis media. So presence of air bubbles and air fluid level is diagnostic of serous otitis media, also called as non-suppurative otitis media, also called as glue ear.
Question 5. Which of the following structures are in close proximity to the affected structure in a 70-year-old male patient presenting with decreased hearing in higher frequencies, where the basilar membrane has been affected? Your options are, and the correct answer is oval window. Here's the explanation.
Phase difference. We have learnt just now that sound gets travelled from the scala vestibuli to the scala tympani. So quickly think and tell me, when a sound comes from the middle ear and hits the inner ear, which window is getting the sound impulse first? So sound is hitting the oval window first or hitting the round window first? Yes, all of you are absolutely right. The sound gets conducted from the ossicles to the oval window first and then the round window. So sound gets conducted to the oval window first and to the round window later. So there is a difference in the time. That difference in the time, we call it as phase difference. So what is phase difference? The phase difference means sound hits the oval window first and later the round window. Now, because we have this phase difference, there is movement happening of this basilar membrane. If this phase difference was lost, what would happen? There would not be an effective vibration of the basilar membrane.
Question 6. What should be the subsequent course of action in managing a patient who arrives at the emergency department with epistaxis, despite unsuccessful attempts to stop the bleeding by pinching the nostrils and nasal packing? Your options are, and the correct answer is ligation of sphenopalatine artery. Here's the explanation.
Initial medical review and resuscitation. So what will you do? You will do a initial medical review and resuscitation. What do I mean by initial medical review and resuscitation? It means that you're going to ask the patient what is the history of bleeding, how the bleeding started, how the bleeding happened, was there a history of trauma, was there a history of any infection, was there a history of any prior tumor or any sinusitis or difficulty in breathing. So associated local causes. You'll ask systemic history also of hypertension, or is there any liver disease, is the patient an alcoholic, which will cause obviously liver disease. You'll ask if there was any renal disease, ask if if this patient is on any drugs. So all this history you will be taking. Simultaneously, your associated staff, like your paramedical staff, will take the blood samples and send the blood samples for assessment of hemoglobin, how much is the platelet count, how much is the bleeding time, how much is the clotting time, how much is the prothrombin time, activated partial thromboplastin time, INR. All of these tests along with necessary renal profile or liver profile are sent, or if necessary coagulation profile based from one patient to another. But basic thing, you will send the blood for investigation for basic diagnosis to understand what is happening in the patient. Also, along with this, you will also put IV fluids, give crystalloids and colloids to replace the intravascular volume, or whatever amount of blood loss has occurred, to replace that you're going to do resuscitation as well. So this entire process where the doctor is also taking history, resuscitating the patient, giving fluids, giving crystalloids, colloids, taking the blood sample, sending it for investigation, all this entire process is called as initial medical review and resuscitation. Now after doing initial medical review and resuscitation, you're going to prepare the patient for nasal endoscopy. So what is the next step? The next step is prepare for nasal endoscopy. Why do you want to prepare for nasal endoscopy? Because you want to see, is there any bleeding happening from the nose actively, and if there is a active spurter, meaning there is a blood vessel that has ruptured and it is bleeding, you can stop it by coagulating it. So you will prepare for nasal endoscopy. So obviously the patient who has come to you is bleeding from the nose. Will he allow you to touch your nose? Because he's already anxious. There is bleeding. So how will you relieve his anxiety? You will pack the nose with cotton pledget soaked in xylocaine and adrenaline. Xylocaine will act as a topical anesthetic, and adrenaline will cause vasoconstriction and decrease the bleeding. So you can give pledgets of cotton soaked in 4% xylocaine plus adrenaline. Okay, so this is what will help the patient to alleviate his anxiety. His pain will come down, bleeding will come down. He will trust you more now to allow you for examination. Now, once you is comfortable and is allowing you for examination, if you happen to see there is a single bleeding point. So on endoscopy, if you see that there is a single bleeding point, what will you do? You will cauterize that single bleeding point. How will you cauterize that single bleeding point? There are two ways, either a chemical cautery or an electrical cautery. A chemical cautery uses the solution silver nitrate. So you can use a silver nitrate solution. Put a cotton bud or a wick of cotton which is rolled on a stick and dip it in 100% silver nitrate. Usually we do not get 100% silver nitrate, but it is the preferred one. Sometimes you get 80-90% of silver nitrate. Today we also get impregnated silver nitrate sticks, like already they have silver nitrate with the cotton bud. So just have to take it and apply it on that bleeding point. So this will help in stopping the bleeding. If you have a single bleeding point, you will do this. Either silver nitrate or cautery. Thermal cautery. So thermal cautery can be either radio frequency, either it can be just your monopolar or your bipolar, which uses electricity to convert into heat energy or thermal energy. This thermal energy will help in coagulation of the blood vessel. So cauterization is done if you identify a single bleeding point. Now, if you are in a situation where you do not have endoscopy at all. So if you have endoscopy, you are going to go and do all of this. But if you have no endoscopy, or on endoscopy you see not single bleeding point, but you see multiple bleeding point. So what will you do if there are multiple bleeding points and there is no endoscopy available? The next step will be to do packing. What is packing? Is it a direct therapy for stopping the bleeding? No, it is indirect therapy. So it is not a direct therapy, it is an indirect therapy. So what sort of packing you will do? Let us understand. Initially, you will do an anterior nasal packing. If anterior nasal packing fails, then you will do a posterior nasal packing. Now, if posterior nasal packing fails, then what will you do? Then you will go for surgery. What surgery? You will go for ligation of arteries. Okay, the ligation of artery begins with first and foremost sphenopalatine artery. So the first artery that you will ligate is the sphenopalatine artery, because that is the artery of epistaxis. If this doesn't come down, then internal maxillary artery. If still it continues to bleed, then you're going to either, operate the ethmoidal arteries and clip the ethmoidal arteries, or the external carotid artery, from case to case situation. So first and foremost, you are going to look for a direct cause of bleeding by looking for endoscopy and if there is a bleeding or a spurter. If there is a bleeding or a spurter, you will cauterize it. If it is not visible or if there is a diffuse bleeding or you don't have endoscopy system available, then you're going to go for indirect therapy. So direct therapy ruled out, then you'll go for indirect therapy. So in indirect therapy, what will you do? You will do packing, anterior nasal packing. If it fails, posterior nasal packing. If this indirect therapy also doesn't work, then what will you do? Then you will go for surgery, which is ligation of arteries. And if this also fails, then you will go for embolization. So if this also fails, then you will go for embolization of the artery. Typically, the spinopalatine and the internal maxillary artery are embolized. Very, very rarely will you have to, embolize the external carotid. Commonly, internal maxillary and spinopalatine are embolized. So this is the treatment protocol for managing epistaxis. Now, what is anterior packing, what is posterior packing, we will understand in detail, but this is in brief. So first and foremost, whenever a patient is presenting to you with bleeding, what will you do? You will do an initial medical review and resuscitation. What is the second step after doing initial medical review and resuscitation? You are going to look for direct causes of bleeding. So in direct causes of bleeding, you will identify, is there a spurter or is there any bleeding source from where the bleeding is occurring by doing an endoscopic examination. On endoscopic examination, if you identify that there is a blood vessel that has ruptured and from there you are having bleeding, you're going to coagulate that either with silver nitrate or either with thermal cautery. It can be radiofrequency, it can be coplator, it can be monopolar, it can be bipolar. Basically, every aspect of these instrumentation utilizes electrical energy to convert to thermal energy, and that will help in coagulation of the blood vessel. That is direct treatment. If direct treatment fails or you do not have facility to provide this direct treatment, then what will you do? The third step is indirect therapy. What is indirect therapy? Indirect therapy involves packing of the nose. So packing of the nose in the form of anterior nasal packing, posterior nasal packing is done. If this is also failing, then what will you do next? The fourth step will be to do surgery. What is the surgery? Ligation of arteries. First artery to ligate is the spinopalatine artery because it is the artery of epistaxis, followed by internal maxillary, followed by ethmoidal or external carotid from case to case situation. We will never ever ligate the ICA because ICA gives branch to the brain, middle cerebral artery, which is the main artery, and hence we do not ever ligate the internal carotid artery. We will ligate only the external carotid artery if required.
Question 7. What is the most likely reason for a patient experiencing breathing difficulties and unsuccessful extubation after undergoing a total thyroidectomy? Your options are. And the correct answer is bilateral recurrent laryngeal nerve injury. Here's the explanation.
Now let us go to understand the causes of vocal cord palsy. Now causes can be many, but the most common cause is traumatic. It can be a direct trauma, it can be a surgical trauma. The most common surgery that is responsible for causing involvement of the nerve is going to be your thyroid surgery. Now in thyroid surgery, we often see the superior laryngeal nerve and recurrent laryngeal nerve getting involved. The upper pole of the thyroid is in very close proximity to the superior laryngeal nerve, and lower pole of the thyroid is in very close proximity to the recurrent laryngeal nerve.
Question 8. A 2-year-old child presented with following X-ray finding. What is the most likely diagnosis? Your options are. And the correct answer is acute laryngotracheobronchitis. Here's the explanation.
Now if you see, this is the air column of a child, which seems more or less normal. But if you see the air column of a child here, you can see there is narrowing at the region of the subglottis. So you can see that here it is narrow. This sign we call it as steeple sign. So what is steeple sign? It is narrowing of the subglottis resembling the steeple of the church. So we have the steeple of the church, right? So narrowing of the subglottis resembling the steeple of the church, we call it as steeple sign, and steeple sign is seen in croup. And what is croup? Laryngotracheobronchitis is called as croup. So laryngotracheobronchitis is called as croup, and this sign is called as steeple sign. Now let us see this image. You are able to see there is a radio opaque shadow in the neck and it appears circular or spherical.
Question 9. Which of the following does not characterize tubercular otitis media? Your options are. And the correct answer is earache. Here's the explanation.
Tubercular otitis media. One only hallmark feature that could come in your examination from tubercular otitis media is it is characterized by permanent perforation. So what is the hallmark? It is characterized by permanent perforation. And second thing is multiple perforation. So these perforations are multiple and they are permanent. If they are permanent and single perforation, CSOM, but multiple and permanent perforation like this, multiple perforations that you see, that is suggestive to you of tubercular otitis media. So multiple ear perforation is the hallmark feature of tubercular otitis media. Okay, so that is something that you should know. Here it is a painless condition having a foul smelling ear discharge. The severity of hearing loss is much more as compared to the disease that you see. So you will see perforation but the hearing loss will be very high. So it is disproportionate. So the amount of hearing loss versus the perforation is disproportionate in a patient with tubercular otitis media. But what is the take home point for you to remember? Multiple perforations is the hallmark of tubercular otitis media.
Question 10. Which of the following statements is accurate regarding keratosis obturans? Your options are. And the correct answer is all of the above. Here's the explanation.
Keratosis obturans. Again, as the name suggests, keratosis is accumulation of keratin. Obturans is it is obliterating the entire external auditory canal. Now, what is happening in this particular disease? Basically, we have in our external auditory canal small cilia. So, what does this cilia do? They will beat so that the squamous epithelium migrates outside. So, they beat so that the anterior and superior epithelium migrates towards the posterior and inferior side, and from there it is extruded out of the external auditory canal. Now, assume there is a patient who has a ciliary motility defect. What would happen in these patients? Can the squamous epithelium migrate? Cannot migrate. So once it cannot migrate, what will happen? Will it get retained in the external auditory canal? Yes. And if it gets retained in the external auditory canal, what will we see? So will we see first initially one layer of squamous epithelium? Over time that you will have another layer of squamous epithelium. Over that another layer and another layer and another layer. That is now completely occluding the external auditory canal. Yes. So the keratin, the squamous epithelium are getting organized, a layer followed by another layer followed by another layer, like an onion skin. That pattern of arrangement is called as onion skin lamellar arrangement. This can be your MCQ. That onion skin lamellar arrangement is seen in keratosis obturans. This will completely plug the canal. But with time, what will happen? Can this cause widening of the external auditory canal? Yes, it will not cause erosion because it's not an erosive disease, but because of the pressure and because of its expansion, it can cause widening of the adjacent external auditory canal. And when it is widening, the nerve that is present below the posterior wall of the canal, the facial nerve, can it get involved in the disease? Yes, it can cause facial nerve palsy. So keratosis obturans can cause widening but not destruction, and it can cause facial nerve palsy. We have learned this is associated with ciliary motility defects. So, can it be associated with other ciliary motility disorders? Yes, it can be associated with sinusitis. It can be associated with bronchiectasis, which are other ciliary motility defects. So, they can ask you which condition in your external auditory canal is associated with bronchiectasis or sinusitis. It must strike to you that it is Keratosis obturans, because it is also a disease occurring due to defect in the motility of the cilia, causing accumulation of squamous epithelium and keratin in the external auditory canal, causing complete blockade of canal, and this in turn results in pain and hearing loss. Typically, there is widening of the canal, but there is no erosion. So there is no erosion, but there is widening. Facial nerve can be involved because of the widening of the canal. Typically, you have to remove this entire plug of keratin, and it is very hard to remove. So typically, the removal is done under general anesthesia or under sedation. So removal is done under general anesthesia or under sedation.
Question 11. What type of lesions are associated with the presence of inspiratory stridor? Your options are, and the correct answer is supraglottic. Here's the explanation.
In epiglottitis, as the name suggests, there is inflammation of the epiglottis. Now, epiglottis is a part of supraglottis. So, whenever there is an inflammation of the epiglottis or the supraglottis, we call it as epiglottitis. What happens in laryngotracheobronchitis, which we also call it as Croup? There is not just inflammation of the larynx, but there is inflammation of the larynx, trachea, and the bronchus. So all the three are inflamed. So inflammation of the larynx, trachea, and the bronchus, we call it as Croup. Now epiglottitis. As you see in the image, there is inflammation of the epiglottis. So you see there is inflammation of the epiglottis. So why should there be an infection or inflammation? It is secondary to what? It is secondary to a bacteria. Initially, we would tell that it is by H influenza, but now we have got vaccination against H influenza. So H influenza induced epiglottitis has come down in the recent times. So in the recent times, we do not have H influenza induced epiglottitis as the most common cause of epiglottitis, because vaccination has reduced the occurrence of the disease, or even if there is an occurrence, the presentation to the doctor has come down. But now what we see is most commonly epiglottitis is caused by Streptococcus pneumonia. So Streptococcus pneumonia in epiglottitis is the most common organism. So we see that epiglottitis caused by Streptococcus pneumonia most commonly. Whereas Croup is a condition which infects the larynx, trachea, and the bronchus, which is usually not a bacterial infection, but it is a viral infection. So it invades the entire larynx, trachea, and bronchus, and it is a viral infection. Usually it is a para-influenza type 1 and type 2. So para-influenza type 1 and 2 are responsible for causing Croup. Now please remember, when I say most commonly para-influenza, most commonly Streptococcus, it doesn't mean that other bacteria and other viruses will not cause this. Other bacteria and other viruses can also cause epiglottitis, can also cause Croup. So we can have epiglottitis because of H influenza, Streptococcus pneumonia, Enterococcus, and so on. And also Croup caused by para-influenza, by rhinovirus, respiratory syncytial virus, and so on. So it can be caused by other bacteria and viruses, but most commonly by Streptococcus pneumonia in epiglottitis, and para-influenza virus in Croup. The age group where the epiglottitis is commonly seen is usually between 3 to 6 years of age. So the age that is affected is 3 to 6 years of age. whereas croup is usually seen between 3 months to 3 years of age. So it is seen between 3 months to 3 years of age. So laryngotracheobronchitis or croup is seen in younger age group, whereas epiglottitis is seen in slightly older children. So I hope you got what is the definition, what is the organism, which parts are affected, and about the age group where they are affected. Now let us understand quickly a little bit of symptomatology. Yes. So when we come to epiglottitis, there is inflammation of the epiglottis or the supraglottis. Whereas in croup, we have inflammation of the entire larynx, the trachea, and the bronchus. So let me mark inflammation with red so that you understand. So in epiglottitis, only the epiglottis or the supraglottis is inflamed, whereas in laryngotracheobronchitis, entire larynx, entire trachea, and the bronchus is affected. Okay. So this is the area of involvement in both of them. So first we will go to epiglottitis, learn its symptom, and then come to croup. So in epiglottitis, so there is inflammation of the epiglottis or the supraglottis, but this inflammation spreads to the adjacent sites like the base of tongue and the oropharynx as well. So you will see involvement of base of tongue and the oropharynx. First of all, whenever there is a swelling of a structure in the airway, will they first and foremost present to you with breathing difficulty? Yes. So typically, will they have respiratory symptoms? Yes. Whenever there is any obstruction or any pathology above the level of vocal cords, we will have an inspiratory stridor. So any pathology above the vocal cord will result in an inspiratory stridor. Now epiglottitis is a pathology above the level of vocal cord. So here you would expect an inspiratory stridor. Okay, so definitely there is respiratory distress, there is an inspiratory stridor. Now, do they have digestive symptoms or symptoms associated with feeding? Because there is inflammation of the oropharynx, the base of tongue and the oropharynx, they can have dysphagia, odynophagia, drooling of saliva, because it is involving the base of tongue and the oropharynx. So when the patient is trying to feed or eat, there is difficulty in swallowing, painful swallowing, even the saliva can't be swallowed, so there is drooling of saliva. So they will have dysphagia, odynophagia, and drooling of saliva. So this is definitely a feature of epiglottitis.
Question 12. Which of the following best describes Pott's puffy tumor? Your options are, and the correct answer is subperiosteal abscess of frontal bone. Here's the explanation.
Frontal sinus infection, frontal osteomyelitis, and if there is osteomyelitis of the frontal bone, we call this condition as Pott's puffy tumor. So what is Pott's puffy tumor? It is osteomyelitis of the frontal bone. This can be given as a IBQ, as an MCQ. So you should know local complication. Pott's puffy tumor is osteomyelitis of your frontal bone.
Question 13. Which is the condition where surgery is done to partially or completely occlude one nostril? Your options are, and the correct answer is atrophic rhinitis. Here's the explanation.
Now let's understand about atrophic rhinitis. What is atrophic rhinitis? The name only is telling you atrophy and rhinitis. So atrophic rhinitis is a condition where there is atrophy of the mucosa of the entire nose, of the septum, of the turbinates, of the paranasal sinuses. So there is atrophy of the nasal turbinates, of the mucosa of the sinuses, and as a result they will have wide nasal cavity. So when there is hypertrophy, there will be narrowing, but if there is atrophy, there will be wide nasal cavities. So in atrophic rhinitis, the nasal cavities are roomy and there will be filled with foul smelling crust. This has been an MCQ in 2021 and they have asked about a question of wide roomy nasal cavities in the clinical vignette and the answer was supposed to be atrophic rhinitis. So in atrophic rhinitis, what do you typically see? There is atrophy of everything in the nose. Atrophy of the mucosa of the nose, of the septum, of the turbinates, of the olfactory fibers. Everything they undergo atrophy. As a result, you will see there is wide nasal cavity. Now, when there is air currents going through wide nose, what will happen? There will be crusting inside the nose. So, we will learn a little bit detail in a while, but this is the basic introduction of what happens in atrophic rhinitis. Now, atrophic rhinitis is classified into two types. The first type is called as primary atrophic rhinitis and the second one is called as secondary atrophic rhinitis. Primary atrophic rhinitis is a condition where we usually do not know the cause for it. There are multiple hypotheses that this could be the cause, this could be the cause, but we do not know the direct cause of primary atrophic rhinitis. But secondary atrophic rhinitis occurs secondary to certain conditions, like secondary to infections like syphilis, lupus, leprosy. It can happen secondary to certain surgeries, secondary to radiation. All this, if it is happening secondary to a certain cause, then we call it as secondary atrophic rhinitis. So primary atrophic rhinitis, usually the cause is not known, and secondary atrophic rhinitis, it is secondary to either infection, secondary to surgery or secondary to radiation, then we call it as secondary atrophic rhinitis. Now primary atrophic rhinitis, I have told you, is most commonly due to an unknown cause and various theories have been put across to understand the causation of primary atrophic rhinitis. So primary atrophic rhinitis is first and foremost most commonly due to hereditary. So hereditary causes have been postulated. Endocrinological causes, it is typically seen that it starts often after puberty, involves more of females and it decreases after menopause. So it starts at puberty, involves female and it subsides after menopause. Racial factors, it is oftenly seen in Afro-American people most often than Asians. Nutritional cause, it can happen due to nutritional deficiencies like vitamin A, D and iron. And then infective cause, this is something that you have to remember, that infection that is responsible for atrophic rhinitis is Klebsiella oziana. Please do not forget this. This is called as Perry's bacillus. This can be your MCQ in the examination, that Perry's bacillus is responsible for causing primary atrophic rhinitis. What is it? Klebsiella oziana. So is this gram positive or gram negative? It is a gram negative organism. So Klebsiella oziana is your gram negative organism. So infection is one of the most important hypothesis for the causation of primary atrophic rhinitis. And last is your autoimmune causes. So if I take a mnemonic for this, would it not be more easier for all of you? Yes. So if we see and join the alphabets of the first letters of all the hypotheses, it will form hernia. H is for hereditary, E is for endocrinological, R is for racial, N is for nutritional, I is for infective and A is for autoimmune. So hereditary, endocrinological, racial, nutritional, infective and autoimmune. If you remember the mnemonic hernia, you will know the causation for primary atrophic rhinitis. Please remember the organism which is your Klebsiella oziana, also called as Perry's bacillus. Klebsiella rhinoscleromatis, which we studied in rhinoscleroma, was your Frisch bacillus. This is Perry's bacillus. So both of them are gram negative. Klebsiella rhinoscleromatis will cause rhinoscleroma. Klebsiella oziana will cause primary atrophic rhinitis. So once you know the causation of primary atrophic rhinitis and secondary atrophic rhinitis, let's go into the clinical features. Typically what we see here is there is something called as merciful anosmia. What is merciful anosmia? The patient himself is unaware of the foul smell coming from the nose, but the people surrounding the patient tell that there is some bad smell coming from this patient. So a foul smell coming from the nose of the patient which he himself is unaware of, what will we call that as? merciful anosmia. So typically there is merciful anosmia and there are wide nasal chambers, but despite those wide nasal chambers, patient will usually say that they are unable to breathe. So nasal obstruction in spite of wide nasal chambers are two important clinical manifestations of atrophic rhinitis. Now let us understand why does this happen. So if you see, this is a image showing you septum. So this is a video showing you the septum. Then we have got the turbinates in the lateral wall of the nose, and then we have got the olfactory fibers in the roof of the nose, and air current goes through the nose. In atrophic rhinitis, what do you see is atrophy of the turbinates and atrophy of the olfactory fibers, atrophy of the mucosa as well. Now because of that, there is wide nasal chambers. Now when air current goes through this wide nasal chambers, there is crusting inside the nose. Now would this crusting allow the air current to reach the olfactory cleft? No. Would this crusting allow the air to go to the olfactory area which is at the roof of the nose? No. Second thing, also because of atrophy of the olfactory fibers. What is happening if there is atrophy of the olfactory fibers? Can the patient perceive smell? No. Patient cannot perceive smell. So patient cannot perceive smell because of atrophy of the olfactory epithelium. Also because the air current that is going into the nose is obstructed by the crust, it is causing anosmia or hyposmia. So this is what happens in atrophic rhinitis, that they will have atrophy of the turbinates, atrophy of the septum, atrophy of the mucin producing cells. And when there is atrophy, when the air goes through the wide nasal chamber with no mucus, there will be crusting inside the nose. This crust will avoid or prevent the airflow to the olfactory cleft, and even if some amount of air still reaches the olfactory cleft, there is atrophy of the olfactory epithelium. And once there is atrophy of the olfactory epithelium, the patient cannot perceive smell. That is why patient has something that we call it as merciful anosmia. So merciful anosmia is a feature that you see in atrophic rhinitis. There are wide nasal chambers and there is crusting inside the nose. So this video summarizes and talks to you about atrophic rhinitis and their symptoms.
Don't forget to like and subscribe if you found the video interesting. See you in the next one.